welcome again to Chair's Grand Rounds. Great attendance already. We've got 68 people online, which is really outstanding. One of the things that's become apparent to me during the course of this COVID is how great the faculty is at stepping up to the plate and volunteering to do stuff. And I've been asking people to do rounds who I think would do an outstanding presentation. I've got way more volunteers than slots, so thank you for that. It's been really inspiring to see. Today's presentation is going to be by Dr. Gerstein. I think probably everybody knows Dr. Gerstein. He's been a master for a few years, as I understand it, and was a long-serving division director for endocrinology, is the associate director of the Population Health Research Institute, has many, many awards and distinctions attached to his name, as well as being a prolific author, and also just a really nice guy who really steps up to the plate when asked to do so. And many of you will know that Herzl has recently been leading a whole series of highly innovative trials looking at novel management strategies for diabetes, and he's going to talk about that today. And while we're going, I apologize for the doorbell. I have to figure out how to turn that off. There's a setting somewhere, but I don't think I can do it while the meeting's live. So, Dr. Gerstein.
Okay, thank you. Thanks a lot, Mark, and thank everybody for coming into to rounds. As I said, this is usually a better attendance than Grand Rounds usually get. So it's great to be speaking to my colleagues who I see every day. Mark said he wasn't sure what day it is. Somebody recently told me that today was Blur's Day, and every day is Blur's Day, and it feels that way sometimes to all of us. So the topic that I thought would be good to share with people is really things that I've been spending my time doing for the better part of my career. And the title is Evidence-Based Reduction of Cardiovascular and Renal Outcomes in People with Diabetes. This is the attendance code, and I'll show this at the end of the presentation as well. And you just simply have to email this code to Gail Campbell, and that's the older approach. So these are the companies that I work with and have worked with in the last few years that have helped to improve the collaborations that help to improve the lives of people with diabetes all around the world. And so here's the outline of what I'm going to discuss in the presentation today. First, it's appropriate to just remind everybody of what the cardiovascular and renal consequences of diabetes are. And then I'll briefly talk about the link of these consequences to glucose and glucose lowering. Then the bulk of the presentation, a good half, is going to talk about, I'll talk about the effect of glucose lowering drugs on both the cardiovascular and the renal consequences, and some really exciting data that the last 5 to 10 years, actually 5 or 6 years, have really brought to us in this field. So first is to remind you that diabetes is really common. So right now in the world, about 1 in 11 people, 1 in 11 adults in the whole world have diabetes. It varies by country. In Canada, but it's not that, doesn't vary that much. In Canada, it's about 1 in 9 adults over the age of 20 have diabetes. Over the age of 75, it's about 1 in 4, 1 in 5. So this is a really, really common disease. The vast majority, more than 90% of people, have type 2 diabetes. The remainder have type 1 diabetes and the other types, pancreatectomies, etc. So it's mainly type 2 diabetes, really, really common. And this prevalence has more than doubled. Actually, it's almost 2.5 times in the last 20 years. So it's, as has the incidence. What about the cardiovascular consequences of this common disease? There's many, many epidemiologic studies I can show you that describe these. This is probably one of the best ones that make the point. This is an epidemiologic study based on a database in the United Kingdom called the Caliber program. In this particular study, 34,000 people with type 2 diabetes were compared to 2 million people without diabetes within the database. And within the database, they were followed for a median of 5.5 years, during which time there were 114,000 first cardiovascular outcomes. And so I'm going to show you first the Kaplan-Meier curves, and then I'll show you the estimates. So Here are the Kaplan-Meier curves, and each curve represents a different cardiovascular outcome. And the red are people with diabetes during this 5.5-year follow-up, and the blue are people without diabetes. And you can see starting in the left, upper left is stable angina, then the next one just to the right of it is unstable angina, then myocardial infarction, and the second row is heart failure, and then arrhythmia, TIA, coronary disease in the top right. The bottom row, you see that the only two outcomes really that are not more common in people with diabetes, in fact, even less, are subarachnoid hemorrhage in the bottom left and abdominal aortic aneurysm in the bottom right. So you can see peripheral artery disease, in the bottom middle is really a big issue. So for the most part, diabetes is no question a clear risk factor for a whole host of cardiovascular outcomes, including heart failure, ischemic heart disease, cerebrovascular disease, etc. The hazard ratios from those Kaplan-Meier curves are shown in this slide. And you see that, like all hazard ratios, to the right of the line of unity is an increased risk, to the left is a reduced risk. The only ones that were reduced for not clear reasons were abdominal aneurysm and subarachnoid hemorrhage, but every other cardiovascular outcome is about a 1.5 to 3-fold risk, the highest hazard ratio being peripheral artery disease, interestingly enough. So I could show you many similar cohort studies. This is a nice one because it shows a whole host of different outcomes in the same study. But generally, a good rule of thumb is that if you have diabetes, you are twice as likely, after adjusting for everything else, to have a serious cardiovascular outcome compared to if you don't have diabetes. And these are most serious cardiovascular outcomes, specifically heart failure, ischemic heart disease, and cerebrovascular disease. So that's an important message going forward. What about renal outcomes? Diabetes is also a really important risk factor for renal disease. Now, the way we classify renal disease in 2020 is based on the combination of albumin in the urine, albuminuria in the urine, and the eGFR. And it's actually, the nephrologist uses kind of orthogonal way of characterizing it. So if you have albuminuria and you have a low GFR, you are very bad. If you have a high GFR and you don't have albuminuria, then you don't have a problem. And you can see in the shaded out area, there's a lot of different subcategories. But the major point for today is that the more albuminuria, and the way we measure it is a single morning albumin to creatinine ratio in a spot urine, and albuminuria doesn't measure, it measures albumin, not total protein, so it includes, so you have a more precise measure there. And the albumin assay measures lower levels than a dipstick does. And then the GFR, we all know the category, so the lower the GFR, the higher the risk. So and diabetes is a common risk factor for renal disease. You can see in this the analysis from the NHANES cross-sectional survey in the United States, a very well-known and representative survey. People with diabetes have an overall prevalence of renal disease of about 44%, and in those age 65, about 61%, defined on the basis of a high albumin to creatinine ratio or a
now that I'm getting burned out in residency, diabetes started to start pretty
Somebody's got a hot mic. Can you turn off your mic? You're talking about residency programs or something. I'm trying to find who it is, but I can't see.
Or a low GFR. The incidence of renal disease and diabetes is about 2 to 4% per year for the low GFR, higher for albuminuria, and the classic risk factors are there. But the most important point is more than half of all end-stage renal disease is related to diabetes and due to diabetes. So, so if you actually go to the dialysis unit, 45 to 55% around the world, people there have diabetes as a comorbidity, and diabetes is probably responsible for a good chunk. And renal disease is also important. The reason I'm highlighting it today is because it is a major risk factor for cardiovascular disease and death. So this is just so shown nicely in this recent epidemiologic study published by an American Journal of Nephrology this year. Again, it's a database study, but 250,000 people with diabetes, 250,000 people, pardon me, in 2 large medical records databases. This is actually, these are people with diabetes who were diagnosed between in the window between 2011 and 2015. And they were classified according to whether they had chronic renal disease and followed within the database for 3 years for major cardiovascular events, heart failure, or all-cause death. And you can see the top 2 curves in these 3 Kaplan-Meier curves are those with renal disease. So diabetes plus kidney disease are in the top 2 curves. The bottom 2 curves are diabetes plus other cardiovascular risk factors, but no kidney disease. And so again, kidney disease is a serious risk factor for vascular and other health outcomes in type 2. And the final epidemiologic point to make just relates to total mortality. And this is again is an epidemiologic study which enrolled 91 different cohorts comprising 700,000 people and 129,000 deaths. And all these data are sex adjusted to age 60 and the mortality I'm going to show you was per 1,000 patient years. So if you look at the bottom line in this slide, you see that if you don't have a history of diabetes and don't have a history of cardiovascular disease, your mortality rate, you see in the bottom row in the first, right beside the curve there is 6.8 per 1,000 person years or 0.7% per year. If you go right above that, if you have diabetes, it's double. It's 1.6% per year, 15.6 per 1,000 person year. So it's about double the rate with diabetes compared without diabetes. And the rate of death in somebody with diabetes is similar to the rate of death in somebody without diabetes but a previous MI, or it's similar to the rate of death in somebody without diabetes and a previous stroke. So that really in a nutshell, and the right side shows the hazard ratios. Again, diabetes is about a 2-fold hazard ratio. So in a nutshell, what I've told you are the epidemiologic relationship between diabetes, renal disease, diabetes, and kidney disease, and the additional risk that kidney disease poses for cardiovascular disease as well. So diabetes and heart and cardiovascular. Okay, the next question, let me just look forward. Yeah, the next question really relates to what is the link of this to glucose? And this is a very interesting question, and it's actually occupied a lot of research time. Well, the first point to make is that there is a clear link to glucose. So the next slide showed this very nicely. An epidemiologic study in which people with diabetes were compared to people without diabetes, but the people with diabetes were stratified according to their hemoglobin A1C. This is a large data study from a Swedish registry, which comprised 435,000 people with diabetes and 2 million people without diabetes that were all matched, and they were adjusted for sex, age, etc. And they were followed within the database for 5 years for mortality. And you can see on the curve that in those less than or equal to 55, the higher the A1C, 6.9%, 7 to 7.8, etc., the higher the mortality compared to people without diabetes. Even the very top line, their A1C less than to 6.9, they still are about twice as likely to die compared to people without diabetes. And the higher the A1C, the higher the risk of death. And that occurs in the younger group, and that trend, the relationship with A1C, is consistent in people 55 to 64, 65 to 74, or 75 and above. And I think the message is that hyperglycemia is clearly a risk factor for diabetes. So it's not just diabetes versus no diabetes, it's also how hyperglycemic you are that drives the risk of mortality. Now, the question that everybody always asks is whether or not this is causal. And that is the million-dollar question. And really the question is, if there is a strong epidemiologic link to glucose, does glucose lowering reduce the consequences? I can tell you that that question is not clearly answered. There have been a number of trials that have randomized people to more versus less intense glucose lowering in type 2 diabetes. These have generally shown a reduction in myocardial infarction, in fact, pretty consistently so, but not a clear reduction in any of the other cardiovascular consequences. They've been relatively short. I'm going to show you one summary of them, and that's in this trial here. This is a meta-analysis of the diabetes trials, which analyze people according to low versus high, less versus more glucose lowering. And you can see for these trials, the three that are positive are highlighted in red: heart disease, coronary heart disease, and composites of coronary heart disease and stroke were very modestly reduced. You see the adjusted relative risks in the middle there of 0.92 and 0.95 and 0.95. So there is a modest effect of glucose lowering in the trials that have been about 5 years duration, 3 to 5 years duration, on cardiovascular outcomes. Not a lot to write home about, but it's a very modest effect. The other thing to tell you, though, is that does glucose cause cardiovascular events? And the answer is pretty much established now that the answer is yes, and that's based on about 4 different independent large Mendelian randomization analyses, which I won't go into unless people ask the question later on, but these are genetic techniques, fairly sophisticated, that can assess causality of various biomarkers based on genetic relationships. So I think that question is fairly established, but so far we have not really been able to show that there's a large reduction in cardiovascular events with more versus less intense glucose lowering. What about renal benefits of glucose lowering? That has been easier to show. So more versus less intense glucose lowering does clearly reduce renal outcomes. And here is a meta-analysis showing a 20% reduction of the 4 major trials which randomized people to more versus less intense glucose lowering and recorded renal outcomes. And that's a fairly consistent finding. So what have I showed you so far? And the rest of the presentation is going to be in the last point. So far, I've reminded you that number 1, diabetes is common and its prevalence has been rising. And right now, as I said, in North America, about 1 in 9 adults have. Number 2, if you have diabetes, you are about double the risk of cardiovascular consequences and mortality compared to if you do not have diabetes. You also have a much higher risk of renal consequences, including renal failure, versus if you do not have diabetes. There is a graded relationship between how hyperglycemic you are and your actual risk of mortality and cardiovascular and renal consequences. So that is clearly a risk factor. I mentioned that it is actually also, glucose is also a causal factor for cardiovascular outcomes, but glucose lowering per se, generically, has not dramatically reduced cardiovascular outcomes, but does clearly reduce renal outcomes. Now, the remainder of the presentation is going to talk about the related question. What about the effect of glucose lowering drugs? And the question is, regardless of how much they lower glucose levels, do glucose lowering drugs per se have additional benefits on serious health outcomes? And this has been really very, very carefully studied in a host of large trials of all the available glucose lowering drugs. So on the slide, I've shown the classes of glucose lowering drugs, the categories of glucose lowering drugs that are available around the world. Most of these are also available in Canada. I'm going to go through these class by class. Understand that my comments are predicated on the assumption that a class effect exists for drugs. So if one member of a number of members of a class have a benefit, probably the class as a rule does have a benefit, etc. So we'll start off with sulfonylureas. These are old drugs, they've been available as a class to treat diabetes and hyperglycemia since the 1950s. There's a whole host of them. Old one everybody knows about is glyburide. The one that's most commonly used in Canada right now is probably glycoside. And these work by kicking the pancreas and getting it to squirt out more insulin, regardless of what the blood sugar is. So they actually push insulin out of the pancreas into the circulation and lower glucose levels in that way. Tell you that there, I'm not going to go show you the data, but there have been only actually 2 reliable large cardiovascular outcomes trials that have assessed the effect of sulfonylurea versus a control agent on cardiovascular outcomes, and these have shown no effect, neutral effect completely. So, and the trials are, there was one trial which showed the effect of a DPP-4 inhibitor versus placebo, showing no cardiovascular effect, and then another trial of sulfonylurea versus that DPP-4 inhibitor showing no cardiovascular effect. So based on those 2 trials, I think the world has agreed that there is no harm or benefit of sulfonylureas on cardiovascular outcomes, and the major effect of the sulfonylurea is glucose lowering, and no effect on renal or other outcomes as well. So what about the remainder of the agents? Once again, just remind you, the way we assess whether any of these drugs have an effect on serious health outcomes is with a large randomized controlled trial where people are randomized to the drug versus a control agent. So does metformin reduce mortality, serious health outcomes, etc.? Metformin is one of the most commonly used drugs. It's been available since the 1950s as well. And there was a trial published in the late 1990s called the United Kingdom Prospective Diabetes Study, which included sulfonylureas and metformin and a bunch of other drugs. And in one subgroup of that study, which included 342 people randomized to metformin, there was a reduction in mortality at a barely significant p-value. And that has actually put a bit of a halo around metformin, but by today's standards of large, big cardiovascular outcomes trials, I think people would not accept that as proof of that, at best, a hypothesis generation. So there is no clear cardiovascular outcome trial benefit of metformin versus placebo or a comparator. It certainly doesn't seem to cause any harm, and it isn't a very effective glucose lowering drug. But as far as preventing cardiovascular events, it remains a speculation. There has been a number of attempts to launch a big cardiovascular outcomes trial with metformin in people without diabetes, and that is still being looked at, and but has not yet got off the ground. There's been some pilots, but the big cardiovascular trial is still waiting to be done. Acarbose is a glucose lowering drug that works by slowing glucose uptake from the gut into the circulation. And it has been tested in one large cardiovascular outcomes trial that was run in China and showed a totally neutral effect on cardiovascular outcomes. It does prevent diabetes very nicely, but does not prevent cardiovascular outcomes. And there are very few people using meglitinides. The example of that in Canada is repaglinide, and it has also been tested in a cardiovascular outcomes trial, showing a neutral effect on cardiovascular outcomes. So the cheapest ones are sulfonylurea and metformin, and they're neutral with respect to serious outcomes. And now, what about the next class? What about insulin? Now, insulin has been around to treat diabetes since 1922, and it is a wonderful drug in terms of preventing death in people with type 1 diabetes and ketoacidosis, and has changed people's lifespans from type 1 diabetes from 1 year to essentially 100 years. So insulin's a miracle for type 1 diabetes. Its role for type 2 diabetes has been debated for also about years, partially because with people attributing insulin to being a harmful drug because people who start insulin are sicker than people who don't start insulin. Until we did a large international randomized trial looking at the cardiovascular effects of insulin versus no insulin, showing pretty convincingly in 12,500 people followed for about 6 years that the effect of insulin on cardiovascular events, the first primary was heart attack, strokes, death. The second one included heart failure, revascularization, and all the components, was totally neutral. So a highly powered, high outcome rate trial showing that insulin, et cetera, does not have a harm or benefit on serious health outcomes, and it does have obviously glucose lowering, clear glucose lowering effects. And the only adverse effect in this trial really was more hypoglycemia in the group on insulin versus no insulin. But the point is that insulin as a drug, and that also includes, by the way, heart failure, which is listed on this as well. There has been some people think that insulin promotes heart failure. It doesn't when you test it objectively. So that's a really important message to get across. So insulin is safe. All the other drugs that I mentioned. What about the next class, thiazolides and diones? These are a very checkered class. There's only two representatives, pioglitazone and rosiglitazone. Rosiglitazone was subject to a lot of politics about 10 years ago and is really not available now. There's been controversy as to whether these drugs increase or reduce cardiovascular outcomes. They do cause fluid retention, and small percentages can get pulmonary edema with this. And that's been an issue. But the effect, the long-term effect on outcomes was not known until this trial was done. So this is a large trial. It was well, not that large, but it was a modest-sized cardiovascular outcomes trial in people without diabetes who've had a previous stroke or TAA, and about 2/3 of them had pre-diabetes. But these were followed on pioglitazone versus placebo for 5 years. And you see pretty effectively that this drug, as a representative of the drug class, clearly did reduce cardiovascular outcomes by about 24%. With in fact, in this big trial, there was no difference in heart failure. And so the drug essentially does have some cardioprotective effects in people without diabetes, and there's no reason to think that it wouldn't extend to people with diabetes as well. And it's not commonly used, but it does have cardiovascular benefits. No clear renal benefits of this one, but no harm either. Okay, the next class of drugs, which has been fairly commonly used, are the DPP4 inhibitors. And these are commonly used today. They are a class of drugs that includes drugs called like sitagliptin or Januvia, which is what it's marketed as, and that's the most commonly used one. Linagliptin is probably the second most commonly used one. And what they do is they work by inhibiting the enzyme that breaks down the drug class noted right after that. So it inhibits an enzyme that breaks down a hormone called glucagon-like peptide. And thereby it prolongs the half-life of nascent glucagon-like peptide, which circulates through your blood. And the drug does lower glucose levels because this hormone does have effects on the pancreas. So if you prolong its action, you increase insulin secretion from the pancreas, but that's about it. And the effect of DPP4 inhibitors on cardiovascular outcomes has been tested in 5 different large cardiovascular outcomes trials, and every one of them has shown a totally neutral effect on both cardiovascular and on renal events. So these drugs lower glucose nicely. They can be combined nicely with other drugs, but they have neutral effects on serious cardiovascular events. But now we get to the interesting stuff. So I already mentioned this hormone called glucagon-like peptide. So glucagon-like peptide is a hormone which is made by the gut, and it circulates through the body. And its normal effect is to increase the amount of insulin that the pancreas makes in response to glucose elevation. So if your blood sugar goes up, the pancreas makes insulin. In the presence of glucagon-like peptide, it makes more insulin. Glucagon-like peptide does not push the pancreas to make insulin when the blood sugar is normal, however. This hormone also acts on the brain to reduce satiety, and it also acts on the stomach to reduce gastric emptying. But it has a very short half-life. It only lasts a couple minutes, like a protein hormone, which is why drug companies developed the class above, the DPP-4 inhibitors, to prolong its half-life. But they also developed another way. They made agonists or analogs of this hormone that act just like it, but have a much longer half-life. So the glucagon-like peptide receptor agonists are modified glucagon-like peptides that last longer. They're injected either weekly or daily. There are now a couple of formulations that are injected weekly. There's even one formulation that is oral, clever way of getting a protein through the stomach into the system, which I won't talk about anymore at this point. But there have been several of these classes of drugs that have been approved for glucose lowering in type 2 diabetes. And they lower glucose. They also lower systolic blood pressure a little bit. Because of the effect on the brain and on the stomach, they actually increase satiety, reduce gastric emptying, and actually weight loss is a common side effect with these drugs. And they actually are remarkably safe. The only major unpleasant side effect is usually 1 to 2 months of some queasiness and sometimes diarrhea that usually passes in the vast majority of people. 7 large cardiovascular outcomes trials have been conducted of 7 different drugs effect on serious cardiovascular, and most of these also assessed renal outcomes as well. 5 of the trials assessed renal outcomes. I'll give an example of one trial and then show you all of them. So this one is the one that was most recently published last year. We conducted the Rewind trial, and this was a trial that asked whether or not the addition of a GLP-1 receptor agonist reduced cardiovascular outcomes more than a weekly injection of a placebo. So it was weekly injection versus a saline injection, essentially. 9,900 patients, middle-aged and older. Only 30% of them had prior heart disease, long follow-up in this particular study. But the design of this is similar to the design of all of the other 6 cardiovascular outcomes trials with these GLP-1 receptor agonists. They were added they or a placebo were added to whatever other drugs the patients were taking, and the patients were followed. So it was a blind study, but there was no attempt to blind A1C or anything else. They were investigators were supposed to manage glucose and blood pressure and everything according to their best ability to do so by guidelines, but then the only difference was they either got the drug or placebo during the follow-up period. And so in this particular trial, I'm just showing you the effect. There is an effect on hemoglobin A1C. There's an effect on weight, effect on systolic blood pressure, heart rate. The effect on weight is modest, usually about 1 to 2 kilograms. A1C, it's actually was not, investigators were supposed to manage A1C equally in both groups. They never do, despite the fact of a blinded trial. So there was a modest difference in A1C. Systolic blood pressure, again, there was a bit of a difference despite the fact that blood pressure was not blinded, so people could manage blood pressure any way they want. And it does increase heart rate, but 1 beat per minute, 1 to 2 beats per minute as well. This drug and all the other representatives of its class. So here's a meta-analysis of the 7 trials that were done without showing you all the details. And you can see fairly consistently that the trials, one of the trial was right in the line of unity, all the others were to the left of the line of unity. Our trial, the Rewind trial, plus the Harmony Outcomes trial, and the Sustain 6 trial and the Leader trial were all positive. When you meta-analyze them all together, you see a pretty consistent, modest, but consistent 12% reduction in cardiovascular outcomes with over a 3.2-year median follow-up period versus some of them had a higher and some of them had a lower effect. Overall, that's the effect. There's and this is the same data, well, the other outcomes as well. So there's the 12% at the top. There's also a 12% reduction in the meta-analyzed risk of death from cardiovascular causes, more modest reduction in myocardial infarction, and a bigger reduction in stroke. And actually, these drugs seem to have a more selective effect on stroke than MI, interestingly enough. And all-cause mortality was also reduced by meta-analysis. So this is a relatively new class of glucose-lowering drugs that clearly has cardiovascular benefits, as well as renal benefits. So 5 of the trials measured renal outcomes. You can see that composite that include albuminuria was reduced clearly by 17%. The major effect is on albuminuria. There is an effect on GFR, but it's much less modest, and that did not reach significance. So you can see there's no clear effect on worsening renal function, but there's a clear effect on the composite that include albuminuria. So much more modest renal effect than the next class I'm going to show you. And then finally is the SGLT2 inhibitors. The last class said 3 drugs are not available in Canada for glucose lowering. Inhibitors are a really interesting class of drugs as well. These have only been in the market for about 6 years, and they work in a totally different way. They work by acting on the proximal tubule in the kidney to block the sodium glucose transporter there. Therefore, these drugs cause you to pee out sugar. They actually cause glucosuria. And an average person taking this drug will pee out about 70 grams of glucose a day. And you might imagine that 70 grams of glucose, remember from medical school, that's 4 calories per gram. So you're peeing out about 280 calories a day. And no surprise, weight loss is one of the side effects of this drug class. The 3 large outcomes trials that were recently meta-analyzed, and there's 2 other ones, there's been 5 altogether. Actually, 6th one just announced their top line result, have tested the drugs empagliflozin, canagliflozin, and dapagliflozin. And these all work the same way. They make you pee out sugar. And who knew these drugs that make you pee out sugar actually reduce cardiovascular outcomes? And so these 3 trials that were meta-analyzed, you can see overall there is a modest reduction in MI, stroke, or cardiovascular death. That's similar to what was seen with the other class of drugs. But the real thing that hit people, their effect on heart failure hospitalization and cardiovascular death, and a lot of it is related to that. You see clearly there's a large effect on this composite outcome. Overall, there's a 23% reduction in this. Heart failure hospitalization alone is about a 40%, 35 to 40% reduction in that outcome. And this has been a huge game changer, both for diabetes, but also for cardiovascular disease. Because a recent trial not shown here also tested the effect of this class of drugs in people without diabetes and with diabetes, so unrelated to diabetes, but people with and without diabetes who have heart failure with reduced ejection fraction, and showed a similar effect. So these drugs are going to become a very important heart failure drug for treating heart failure with reduced ejection fraction, regardless of diabetes status. And there's some ongoing studies that are testing it for heart failure with preserved ejection fraction. So these have been a brand new class of agents for treating heart failure and preventing heart failure in people with diabetes and in people without diabetes. All-cause mortality reduced as well in those 3 trials. And who knew a drug that makes you pee out sugar protects your kidneys? Reasons that it does that are very interesting. Probably what happens is because of something called tubuloglomerular feedback, you're reducing pressure in the glomerulus by causing constriction of the afferent arteriole into the glomerulus. But there's a very robust 45 to 50% reduction in serious renal outcomes, such as renal dysfunction, end-stage renal disease, or renal death. With these 3 drugs that I mentioned earlier on, in addition to another one I'll tell you in a second. Side effects of these drugs are very infrequent. The most common nuisance side effect is yeast infections that affects 10% of women and about 3 to 4% of men. And usually occur once or twice and they stop happening, probably related to moist perineum if there's glucose in it, in the moisture, and hygiene may help with that. The much rarer side effects, there's been a slight increase in 1 trial, amputations in the foot, and was about 20% increase rate, and that does not seem to be a problem when people have been more careful about selecting their patients. Interestingly, a meta-analysis of diuretics old diuretics also shows an increased risk of amputations, a slight increased risk of amputations. So it might be related to the glucose diuresis effect. DKA has been something everybody sees one or two of, but the actual incidence of this is about twofold higher than the placebo, about 0.08% per year in people on this class of drugs. Very rare side effect, but it does happen. And like other drugs, this is a class of drugs that people should stop when they have an intercurrent illness that causes dehydration, because that's when the problems occur. And then finally, this class of drugs was tested in people with renal disease, and people who actually had a low GFR, and 4,000 people were followed for 2.5 years. The trial was stopped early, showing a very dramatic effect on reduction in end-stage renal disease in people who already have renal disease, as well as cardiovascular outcomes, as you might have expected as well. So that really, in a nutshell, is a summary of the positive and the neutral large international trials that have assessed the effect of all this new classes of glucose-lowering drugs on serious health outcomes, including specifically cardiovascular disease, renal disease, and other ones which are obviously measured as well. Not to forget that there are other ways of preventing serious health outcomes in people with diabetes that are unrelated to glucose lowering and glucose lowering drugs, including smoking cessation. I continue to be shocked at how many people with diabetes continue to smoke. If you look at every single cardiovascular trial, and these are healthy people that presumably, healthy enough to volunteer for a trial. I mean, sick enough to be in a trial, but people who volunteer for trials are generally healthier than people who don't. There's always 15% of them smoke. And these are people with diabetes and other cardiovascular risk factors. So smoking cessation still is a big challenge in people with diabetes. Blood pressure lowering clearly has renal and cardiovascular benefits. Statins in people with diabetes or PCSK9 inhibitors clearly have cardiovascular benefits. This drug called icosapent ethyl, which is a modified high-dose omega-3 fatty acid. Low dose, 1 gram a day of omega-3 fatty acids are totally neutral in diabetes. High dose, icosapent ethyl, this particular one did have a cardiovascular benefit in the trial published last year. So, and this from people with diabetes who had slightly elevated triglyceride in addition to lower HDL. So this is probably going to become an addition to our therapeutic arsenal. Obviously, renin-angiotensin drugs clearly have renal and cardiovascular benefits in people with diabetes as well as people without diabetes. And antiplatelet drugs do have a cardiovascular benefit in people with diabetes, but in order to have a benefit which exceeds the risk of bleeding, they have to have high CV risks. So aspirin for everyone with diabetes is probably going to cause as many bad bleeds as it is going to prevent heart disease. And that was shown in a large trial called the ASCEND trial of primary prevention, where they randomized people without a previous event to aspirin versus placebo. There's a benefit, but the benefit is the absolute risk reduction is equal to the absolute risk increase of serious bleeds. That's why it's really being not recommended for primary prevention type patients. And the same with factor Xa inhibitors in high-risk patients for sure, low-risk patients not. What are the take-home messages? And I leave 15 minutes for questions. If I was the President of the United States and I was tweeting about diabetes, I would say diabetes, bad, very bad. So yeah, it does increase the risk of many serious health consequences. I just focused today on cardiovascular and renal consequences, but diabetes is also an independent risk factor for cancers, almost every cancer except for prostate cancer, cognitive decline and dementia. And these are the two big epidemics that are chronic disease epidemics that are facing us in the 21st century. And so in addition to a host of other problems such as amputations and other things. So diabetes is bad. It increases the risk of cardiovascular and renal outcomes in addition to everything else. Glucose lowering modestly reduces some cardiovascular outcomes, but clearly reduces renal outcomes. more importantly, at this point, in terms of effect, some glucose-lowering drugs, in addition to lowering glucose, also reduce outcomes. So the GLP-1 receptor agonists, and the three I've listed here are those that have actually had positive trials, but as a class, it probably is the same effect, do have a reduction in ischemic heart disease and strokes and renal outcomes. SGLT2 inhibitors have a bigger effect on heart failure and a bigger effect on renal outcomes and some effect on ischemic heart disease. Pioglitazone, as a representative of the TZDs, the only one available really, does have a benefit in ischemic heart disease. And then obviously several non-glucose lowering drugs also reduce outcomes in people with diabetes, just as they do in people without diabetes. So, I've been, as Mark said, I've been around for a while. I started as a clinical scholar at McMaster in 1987, believe it or not. And when I started doing outcomes trials and assessing the effect of various therapies on outcomes in people with diabetes, my common reaction people would say is, why are you wasting your time? We know how to prevent problems in people with diabetes. All you have to do is this, and this. And that kind of taught me that, we always know exactly what to do and how to manage any of our patients when we don't have any data. And it really has been, in the last, I would say the last 20 years, it has been a huge proliferation of large international placebo-controlled and controlled randomized trials in people with diabetes that have told us tremendous amounts, things that we never would have expected, and also destroyed other misconceptions. So after 15 to 20 years of good large outcomes trials, we've actually learned how to new ways of reducing serious health outcomes in people with diabetes based on therapies that actually we didn't even imagine that they would, such as the SGLT2 inhibitors or even the GLP-1 receptor agonists. So with that, I'm happy to stop and I'm happy to entertain any questions. I have not seen any chat things, so Mark, I'm going to have to rely on you to moderate that.
Yeah, great. Thanks, Herzl. That was really outstanding, as always. A couple of people have asked for the code for the people who are on the phone. It's up on the screen right now, but for those who are on the phone, it is CH2298. That's Charlie Hotel 2298. Something that's near and dear to my heart, Herzl, as you know, is weight loss. Could you comment on the value of weight loss, particularly as it interacts with the value of newer anti-diabetic?
Yeah. So that's a great question, Mark. The GLP-1 receptor agonists, as I showed you, one of the side effects is weight loss. And at the doses that have been tested in cardiovascular outcomes trials, it's about a 2 to 3% average weight loss. That means some people lose a lot more, some people don't. But this side effect, which is due to an effect of the drug on the brain to reduce appetite, as well as an effect on the stomach to reduce gastric emptying and increase satiety. This side effect was not lost on the pharmaceutical industry, who said, hey, maybe we have a weight loss drug class here. And lo and behold, they've been developing these drugs as that. So liraglutide, which was originally marketed as a diabetes drug, was also tested in a higher dose formulation. The glucose drug was called Victoza. The weight loss drug was called Saxenda. So it's a higher dose formulation, which actually has more of a weight loss effect, and it is actually marketed as a weight loss drug and in people without diabetes as well as those with diabetes. So, and that's one of the companies, Novo Nordisk. They're actually also exploring their other drug, their weekly drug, as a weight loss drug as well. So the class of drugs as safe, effective weight loss agents is taking off. And they actually, as I said, there are really no serious side effects with this class of drugs. The nuisance side effects are nausea, sometimes vomiting if you don't slow your food intake, because it does slow gastric emptying. And a lot of patients who take these GLP-1 receptor agonists with diabetes, and even without diabetes, if they're taking for weight loss, they'll say that their appetite's gone away. It just reduces their appetite, and I've had many patients who say, I have to force myself to eat my meals. And, there's not profound weight loss in most patients with diabetes, but at the higher doses, there's more weight loss. And I think, we might see 5 to 10% average weight losses, or even more with some people with these drugs. So there is a potential there for sure. The SGLT2 inhibitors also cause weight loss, but that's actually higher dosages are not going to cause more weight loss, because weight loss is due to the fact that you're peeing out calories and most people's brain picks it up and you actually increase your caloric intake in response to the fact that you're losing more calories. But they're being used in kidney disease now too, to help slow the progression to renal failure. And that's a huge effect of this drug.
Thanks, great rehearsal. Question here about what's the potential mechanism by which SGLT2s might reduce heart failure in non-diabetic?
That's a great question. I think I should leave it at that because there's a lot of debate about that. There's a huge amount of debate. Why should peeing out sugar do that? And I think a lot of people have said, well, there may be a hemodynamic effect because this is effectively an osmotic diuretic. And this is the only time one has ever tested an osmotic diuretic in people with heart failure. And in fact, if you look at the survival curves, they diverge very quickly after starting them. So it doesn't seem to be due to a remodeling effect, but there's also a lot of discussion about energetics and other potential mechanisms whereby the drug itself may be having effects on the heart. But I think at this point, it remains a question for which there's no clear answer that everybody agrees with. So I'll leave it at that.
Great. There's way more questions that we're going to have time to address. So I'm going to cherry pick a couple here and I'll open the mic up in 1 second. From Ann Holbrook, are there any good quality specific data on the influence of the anti-diabetic therapies on cognitive function over time?
Well, that's a great question. In the Rewind trial, we actually measured indices of cognitive function, and those analyses are about to be finished. So I'm not going to share them yet until we're sure about what we saw. But the answer is at this point, no, we don't know any clear evidence for sure. But cognitive measures, actually, I can tell you though that there was a small trial with one GLP-1 receptor agonist suggesting that there may very well be at least it was a proof of concept study that there may be a small effect, and cognitive measures have now been included in some of the ongoing trials of GLP-1 receptor agonists. So I think of all the classes, that is the one where I think there might be something, but it is still early on right now. And so stay tuned for that one.
Excellent. Okay, so one more question from me and then mic's open after this. So in question from Dr. Killian, so in 2020, how does one, if resources weren't an issue, how would one sequence the treatment of type 2 diabetes? What would be the drug that you'd use first, second, and third?
Well, Kieran, that has actually become a bit of a contentious argument between Cardiovascular Society, the European Cardiovascular Society, and the European and the American Diabetes Association. But I think there's no right answer to the question. Just like if you had the same question about blood pressure management, I don't think there's one right answer to the question. And my personal approach to that is you want to look at the patient and what the risk of. They're high risk of cardiovascular outcomes, then I think you need to use a drug that has, in addition to having glucose lowering effect, has an effect on reducing cardiovascular events. If you're really concerned that they're high risk of heart failure, I would go with the SGLT2 inhibitor. If they got renal insufficiency, I think that's also a great drug to use early on, very early in the therapy, if cost is not an option. The big debate is, should metformin always be the first line therapy, which is what it currently is in some guidelines, and Europeans say no, and Americans say yeah. So, but I think it's a bit of a tempest in a teapot. I think you got to judge the patient and see what is going to do the best for them.
Excellent. So I'll ask if anybody wants to unmute themselves and ask a question. We'll give people a moment to figure out how to unmute themselves. Nobody is doing so, so I'll just continue to ask them out of the chat function, but interrupt me if anybody wants to unmute themselves and ask a question. Comment from a question on primary prevention of diabetes. Any thoughts on optimal ways of doing
Yeah, so there have been studies, and we and others have done studies of various drug and non-drug therapy. So there's no question that in a big trial, NIH sponsored about 15 years ago, metformin does reduce new onset diabetes and people with pre-diabetes, so people that have high glucose levels, not in the diabetes range. Metformin is effective, and the other thing that's effective is physical activity and dietary change. So about 30 minutes of, this is where the 30 minutes of brisk physical activity at least 5 days a week comes from, and a 5% body weight loss. So people randomized to that lifestyle therapy versus usual care, those people had a 50% reduction of new diabetes compared to those in usual care. So lifestyle does reduce incidence of diabetes by about 50%. Metformin does, and acarbose does, as well as the thiazolidinediones, pioglitazone and rosiglitazone. So there are a number of drugs as well as other therapies. The effect of GLP-1 receptor agonists on reducing new diabetes is actually being assessed right now in people without diabetes, and that may be the next class. So there's a whole host of therapies, including lifestyle.
Thank you.
A quick question over here.
Yes.
Hi, Herzl. This is Patrick. Quick question on say Jardiance or empagliflozin. On patients with already PAD that we recognize that they have high cardiovascular risk.
Yeah.
Is there, say, a degree of severity of PAD that you wouldn't recommend this, having the risk of amputation in this patients?
I think you have to assess the. I think you have to assess the patient. So the absolute risk of amputations may very well be higher, and people have will be higher. And people have other risk factors for amputation. So if they have a high risk of amputation, then I think you'd be much more cautious about adding this drug. But you have to look: do they have neuropathy? Do they have foot ulceration, etc.? If they've already got things that are putting them at risk for amputation, I probably wouldn't, because you're just adding something else. But just peripheral artery disease alone, if they've got reasonable perfusion of their limbs and they don't have bad neuropathy and they can actually take care and they're on top of it, I think you're safe. But I think it has to be used on a case-by-case basis.
All right. Thanks very much.
Just building on that, there's a question here about black box warning. So does one of the products actually have a black box warning for amputation?
The SGLT2 inhibitors do, based on the one trial that I pointed out, the Canvas trial, which there was an unexpected increased risk. And I showed you the absolute increased risk there. It was about 0.5% in the placebo group, and it was about a 1.26, so it was about 0.7% or so overall increase. So yeah, it is somewhat increased, which is exactly what speaks to Patrick's question. It's why you need to assess the patient. If you think they're high risk for amputations based on their other assessments, then it's a drug class to avoid.
Perfect. Thanks very much. We should probably call it there. We're just right on time at the moment. I'd like to just take a second to thank Dr. Gerstein for stepping forward to do rounds. They were really outstanding. Next week, another great speaker from McMaster University. And I'd like to thank the attendees. We got 127 people at peak today, a lot of faculty members, so that's really outstanding attendance. Thanks so much, everybody. Again, thanks for your continued hard work during the COVID epidemic, and thanks to our doctors also who are keeping us going while we're working our way through. We'll close now and talk to everyone next week at the same time. Thank you. Bye.
Thanks very much.